Thank you for this opportunity. Professor Jawad, it's so nice to meet you during our PAUSE conference, which put some seeds on these new endeavors, and we're able to do new knowledge sharing across the continents, across the countries. Small words about myself. I am Ananda Dhanashekaran. I am a consultant from Birmingham City Hospital. We are newly building a hospital which is known as Midlands Metropolitan Hospital. You can see that building coming up in the picture. Hopefully, in the next few years, we should be able to do a good world-class endourology conference in the new hospital, and I will be able to invite you all and render my hospitality. Apart from being a consultant in Birmingham City Hospital, I am also an associate professor in University of Birmingham and Ashton University. Those two are my main medical schools with which I work. Today, we are going to discuss something absolutely new. I am sure for 90% of the audience, this topic will be absolutely unheard of. But for 10% of the people, you may have heard maybe in some conference or maybe some publications, but you may not be knowing much in detail. The new procedure for prostate by name iTind. In the recently concluded PAUSE 2023 meeting, I presented the details on the Resume, which is another very evolving but very nicely established BPH treatment technology. Compared to Resume, iTind is much more new one. And apart from this, we have other technologies like Eurolift, Optilium, and few other things on the way. We can discuss those things in the future meetings. Now, before getting into the actual iTind discussion, why we need to discuss this? There are 2-3 reasons behind this. Number one, I can say sometimes it will take maybe 1 year, 2 year, or a bit longer time for this iTind procedure to reach your country. But it's always nice to know what is happening. It's nice to know what is correct, what is wrong. It's nice to know what is the difficulties with this procedure. So in the future, at least when it comes to your hand, you will be what they say like standing on the shoulder of the giants. You will be much more equipped with the knowledge and power to do the things. As we know, for the prostate, for male LUTS, we start with lifestyle changes. I'm not sure how many of you focus on lifestyle changes when patient attends the clinic. In my practice, I will literally spend at least 10 to 15 minutes to explain to them everything like appropriate hydration, avoiding constipation, cutting down the caffeinated drinks, cutting down the smoking, and various lifestyle changes. It will help a lot, not just with the patient's urinary symptoms, it will also help a lot with their overall health, which we all know. So the first thing is the lifestyle changes. The second thing is the commonest used medications, as you all know, alpha blockers and 5-alpha reductase inhibitors. Depending upon your country, it may be tamsulosin, sildosin, finasteride, utasteride, etc. And when patient fails these medications, they will end up most probably into TURP, which is commonly monopolar, if not a bipolar TURP. Of course, lasers, enucleation of the prostate using lasers, even bipolar diathermy is now very much practiced and very much expertise in the world. Why we need something in between this medical treatment and TURP? Why we need these minimally invasive treatments like iTind, Eurolift, Resume, Optilium? Why this is needed? The reason is, of late we are seeing a lot of young patients, 48-year-old, 52-year-old, who are sexually active, presenting with symptoms but not responding to the medications. Of course, there is a big chunky reason that there may be some significant lifestyle changes, work or family related stress, and so many things. But to a certain extent only, as a urologist, you can act on those psychological and physiological phenomenon. End of the day, patient wants something and tamsulosin is not working. Finasteride is giving problems with libido or erections. So If you put this patient to say enucleation or TURP, that further jeopardizes his erection and ejaculation capacity. I've come across few people in the region of 48, 50-year old who still want to have one or two children and just starting the family, maybe a second marriage, having a young wife or girlfriend. So for all these patients, we do a big disservice if you don't give the options of this minimally invasive treatment. All these minimally invasive treatments, iTind, Resume, Urolift, Optilium, they have few things in common. First thing, they don't affect erection or ejaculation much, which is a very big relief. Most of the procedures can be done in a very ambulatory setup, which means patient can just walk in, have the procedure, 2 hours time with a cup of coffee or tea, he can walk home. They are quite good for patients who are taking anticoagulants. We do stop the anticoagulants, but it is less bleeding, no need to stay in the hospital with a catheter, irrigation, 1 night, 2 nights, etc. The whole complexity of TURP is released. I will discuss much more detail in the following slides. So iTind is a device which has got, as you can see here, like three prongs. I will try to show with the help of a pointer. Yeah, so three prongs. So these three prongs help in opening the bladder neck and also making cuts in the prostate, which I will show with much more clear videos. And there is a tongue-like prong. You can see that this one will be useful to hold the iTind in position for that 5 to 7 days. So it's a temporary implanted nitinol device. It has got three arms, 5 o'clock, 7 o'clock and 12 o'clock. And there is an anchoring leaflet at the 6 o'clock. The advantage of nitinol is you may have come across kind of a stent like mammocath. So the nitinol is a material which is very soft when you expose it to cold water. In the room temperature also it is relatively soft. But when it is heated up either in normal saline or when it comes in contact with the patient's body, because of the body temperature being say 37 degrees Celsius, it becomes quite stiff. So that stiffness makes the thread to cut the prostate and create the three channels, which opens the bladder neck and also helps to relieve the urinary symptoms. Okay. Now it works like this. When you place the iTind device will be placed in the prostate, predominantly aiming at opening the bladder neck. And we know that the prongs should never cross the veru or the sphincter. If it crosses the veru, it can cause problems with ejaculation. If it touches the sphincter, obviously there will be problems with urine leakage. Once you keep the prongs like that, in 3 to 5 days, the prongs slowly open up, creating the nice channel. And then even after removal of the temporary implant, you can see that the channel is nicely maintained like this. Okay. Now this is the real patient scenario. You can see before placing iTind, there is a good obstruction. And after placing the iTind at 7 o'clock, there is a cut. And this is the cut at 12 o'clock, at 7 o'clock, and this is another patient with a cut at 12 o'clock. So overall, you will get these kind of three cuts, almost like a Mercedes-Benz sign cut. So which patients are suitable for this? Patients between 50 to 90-year-old. The reason why we say it's 50 to 90-year-old is in the initial studies when they are doing iTind introduction, the studies were done with this selection criteria of 50 to 90 years. But if the patient is 48-year-old or 49-year-old and you feel the medical management is not working and you feel the patient will better with iTind procedure, you can offer the procedure, but you may have to document to say that this is registered and licensed for patients between 50 to 90-year-old. Again, there is no restriction to use for a 91-year-old or 95-year-old gentleman. but the prostate size should be less than 60 cc, because this is not a procedure which creates a cavity in the prostate like TURP. It only makes a cut. This is almost equivalent of like a Collins knife bladder neck incision. When we are using a Collins knife, monopolar or bipolar bladder neck incision or laser bladder neck incision, patient needs a catheter. Patient may need irrigation. Patient may have to stay overnight, while iTind makes those things quite minimal. And patient should have predominant voiding symptoms. As you know, voiding symptoms means patients got weak stream, straining to pass urine, difficulty in initiation urine, difficulty in completing the urine, feeling of incomplete emptying. They are all voiding symptoms. While storage symptoms are the FUN, F-U-N, frequency, nocturia, and urgency. If the patient presents with predominantly storage symptoms, we need to be careful because the problem or pathology may be in the bladder. If the pathology is in the bladder, it's better to do more bladder training, anticholinergics, mirabegron, etc., and not to go for surgery directly. If there is a patient with predominant storage symptoms, we may have to do even a urodynamics to prove that storage symptom is secondary to bladder outlet obstruction before we can offer any bladder outlet obstruction procedure. And it's nice to select the patients with failed medical management, because if medicine works without much side effects, there is no point in patient undergoing all these procedures. Nice to have baseline uroflowmetry and IPSS scores, and counseling and consent will be very, very important. The procedures, at least first 3 procedures, you may have to do it in a proper theater setup, at least IV sedation or maybe a short GA. Once you are confident, once the learning curve is achieved, the procedure can be done in your day unit, in your ambulatory unit or endoscopy suite under local anesthesia. Pre-procedure, patient needs antibiotics, a standard antibiotics like what you may give for your TURP, any antibiotic based upon your local antibiotic principles. In England, we use a single dose of IV gentamicin. If not, maybe an oral ciprofloxacin 500 milligrams 1 hour before the procedure. Post-procedure, if the patient is voiding well, patient will be discharged. Removal of the device will happen 5 to 7 days. If patient can tolerate well the device, it's nice to leave it for 7 days, but removal in 5 days has equally good outcome. Removal can be done under local anesthesia. It can be done in your endoscopy suite or outpatient clinic or procedure unit. You may be having a small procedure unit where you can remove the JJ stents, doing circumcision, etc. And it's very important to do a prospective audit to keep an eye on your outcomes, and you need to discuss with your local clinical governance. I will show you a short video which will explain the procedure in detail. So this is the video. So as you can see, the right side you can see the animation. We are doing a cystoscope, and during the cystoscope you can see that the patient's urethra is normal, sphincter is nice and functioning, and the veru is nice and prominent, and you can see that the patient's prostate is just coming to the midline, not a very obstructive one, but the bladder neck is definitely on the higher side. And the bladder is normal. There is no signs of any TCC or stones, but there is some diverticulae or trabeculations as you have seen. So we are emptying the bladder. Once the bladder is emptied, this is the iTind implant. So the iTind implant will be kept through the sheath, and initially the implant will be blindly inserted. When we are inserting this implant, with the help of your hand, you will feel that the implant is going through the cystoscope sheath, and when it goes into the bladder, you will have a kind of a release feeling in your hand. Once you are sure that it is nicely released, then the sheath can be removed. The implant is connected by this inserting wire, and then you need to reassemble your cystoscope sheath, and you need to go by the side of your iTind implant. So when you are going by the side of the implant, you can see that the implant is better to be kept at 6 o'clock, and your cystoscope should be on top of your iTind device. So now the device has reached the bladder. you can see that the iTind's 3 prongs were there, and this is the tongue-like retaining device. The tongue should be at 6 o'clock. You can adjust it with the help of your hand and make sure that the tongue is at 6 o'clock, and slowly try to take the implant back into the prostate. You can see that one prong is nicely making a cut at 12 o'clock. The other 2 prongs were making a cut at 5 and 7 o'clock. And under vision, the cystoscope sheath and the implant were brought back, and the tongue should sit just before the veru behind the bladder neck. So the tongue will retain the implant exactly in the correct position where we wanted. Once this position is achieved, you can empty the bladder using the sheath. You can see that the tongue should be nicely placed in the floor of the prostate. Then we can cut that inserting prong, and the whole inserting the loop can be removed. There will be a thread hanging out, and the thread can be nicely secured into the patient's penile shaft, and this patient should be handling it with carefulness, and make sure it's not too wet, make sure the patient is not removing it. As you can see here, when we are leaving this implant for 5 to 7 days, the implant with the body's heat will slowly open up and create that nice 3 cuts in the prostate. Now we are going to see the removal of the device. So this is after 5 days. So removal can be done when patient is lying flat, supine position, and we got this thread which is hanging outside. So we have a kind of a removal device like a stainless steel thread. Nicely connect that stainless steel loop to the existing thread with 2 or 3 nice surgical knots so that it is nicely anchored, and then we pass a open-ended 22 French silicone catheter. So this open-ended catheter, when it goes along this thread, how it happens is the implants are nicely opened up. Now this catheter will grow and close the implant, and then when you remove the catheter, the whole implant will come out. So removal will just take 20 seconds. Patient will feel it, but if you're giving enough lignocaine, lubricants, it's a tolerable procedure. It's almost like a difficult JJ stent removal under local anesthesia. So now the catheter is passed in. So when the catheter is passed in, as you can see, it requires a little bit of force, and you need a second assistant to hold the thread taut. So when the catheter goes in, the catheter tries to close the iTind implant into its lumen, and you can see that the catheter is now removed. So it will go into the lumen, and the whole catheter will be removed back. So that's it, the procedure is done. It's a very simple procedure. It should not take more than, I will say, 5 minutes to 6 minutes to kind of reimplant it, and then maybe another 30 seconds to remove it. It says we have another 10 minutes in the Zoom session. As we discussed, if I get logged out, I will log into the same account. Okay. Now, what are all the clinical data? So what is happening in the research field as of now? So there are plenty of data, lots of publications from Canada, America, European countries, and these 4 are the main studies quite recently, 2021 and 22 and 23, comparing iTind with sham. Sham means we are doing a cystoscope, but we are not placing the iTind inside. So it's like a sham procedure in essence. So if the sham procedure gives an improvement, how much more the iTind is giving the improvement. And then we have another prospective single arm multi-center study, another randomized control study, and prospective single arm another multi-center study. And the studies, I don't think how much will be useful to the audience at the present time, but as you can see, patients had a good improvement in their mean IPSS and Qmax. The post-void residual urines were quite high in the baseline, and this is the quality of score. So this is the baseline characteristics. What is the prostate size? What is the age? What is the IPSS score, etc. And you can see we started mostly IPS score around 22 or 23, and then as the patients were followed up for 4 weeks, 6 months, 12 months, there is a good decrease in the IPS score, and the Qmax uroflowmetry increase also nicely maintained for up to 3 years now. So we don't have very long yearly 10-year 5-year studies, but 3-year study shows that the input is quite good. And here you can see the outcome where we have the baseline IPS score and the good improvement of IPS score in 4 to 6 weeks time, and it maintains up to 36 to 48 months, and Qmax also has got good improvement. What are all the adverse effects? Since this implant is going to be there for 5 to 7 days, that 5 to 7 days are very crucial. Sometimes patient will feel quite a good amount of discomfort. I heard sometimes patients even try to call the doctor to see can we remove the implant in 3rd day or 4th day itself. That's why a good counseling before the procedure is very important, so that the patients nicely understand that it works by literally by physically cutting, and that creates a lot of inflammatory reaction. Patient needs to continue with tamsulosin, sulfasalazine, mirabegron. Some surgeons give even steroids, good amount of NSAIDs and painkillers, and also maybe something like sleeping tablets in the night, etc. So those 5 days will be slightly on the difficult side, which patients should accept. The common side effects, adverse effects are dysuria, hematuria, pain, frequency. It can get urinary tract infection. That's why we need to make sure that patients are screened well, and the UTI episodes should be absolutely ruled out before implanting the procedure. And patient may have transient urinary incontinence because placing the cystoscope, removal of the sheath, etc., etc. But usually all these adverse events are quite short lasting. And the adverse events were seen in the region of 10% to 15% in various studies, if you see this one. And retreatment rates, this is very important. There are some early studies which showed 5% of the patients may require retreatment in 1 or 2 years. I will say the retreatment will happen only if we are selecting patients which were not absolutely in the correct indication. If the prostate size is more than 60 cc, if you are doing a cystoscope, and if the prostates are very meaty and obstructing, those patients don't do well. We need prostates slightly on the smaller size, and we don't want a meaty obstructing prostate lobe. We are treating more of a high bladder neck or tight bladder neck. That's understanding should be there. And there are plenty of publications, plenty of references to this. And so this is one abstract from the World Journal of Urology, quite a 6 months interim study, which is called as the Medical Technology 06 study. And there is one publication in British Journal of Urology, which is a 3-year follow-up of the iTind, and publications in the Urology Journal for multicenter randomized controlled trial. And the 3-year results were also published in prostate cancer, prostate diseases, and our own England-based NICE guidelines have accepted it. The acceptance of the NICE guidelines is not something where it gives you a complete independence to do iTind to any numbers. It is very cautious acceptance, so that you can do it in the correct clinical governance and correct audit based setup. And but the guidelines are there to support us, and American urology guidelines are supporting that. And European urology, I think it's still quite early days. Maybe in 2024 EAU guidelines you can see this start appearing. So that's my overall presentation, and we have 4 minutes left. We can do some discussions, and I'm quite happy to answer some questions also in the meantime.
Yeah, thank you very much, Ananda. It was an excellent presentation. We enjoyed well, and I hope faculty, if is having a question or postgraduate, definitely ask the questions. I have 2 questions and comment as well. One question is it a reusable device?
No, it's a single use device. So, since we are keeping inside the patient during that 5 to 7 days, the implant will get infected or it will get colonized with the patient's own commensals in the urinary tract. And also, when we remove it by using that catheter sheath, the implant will get deformed. And so, it is a single use device. And once we used it, and it's going to the bin.
Yeah, thank you. In developing countries like in Pakistan, I don't know the exact cost of this device, but I think maybe $5,000 plus.
Yeah, I mean in UK pounds it comes to around 1,500 pounds, or the correct price is something like 1,440 pounds. The implant as such is 1,500 pounds, we can say, but the procedure and those things gives some extra cost. It is acceptable and we are doing it in NHS. So in NHS we have a package, and if we see the cost for the implant, cost for the theater, and cost other miscellaneous costs like normal saline, etc., and then if we have the NHS tariff, it is quite manageable. So it is a profitable procedure for the hospital in NHS. So the cost will be like 1,500 pounds.
Hello, Dr. Ananda, Dr. Taimur. A nice presentation. I have got two questions. Number one is technical. What size of open-ender catheter you are using, and does it come as a part of the device or using another catheter? Second, have you ever encountered or written any data, any mechanical failure while removing this device?
Yeah.
And second question, especially for our residents, is when to choose this treatment, which is a local treatment, when you compare it with Eurolift, though it has a long, it has been performed since long, and it has more data comparatively to iTind, because newer gadgets are coming to replace the old thing. So in long term, what do you see? Thank
Yeah.
you.
Yeah, so the catheter is a 22 French open-ended catheter. It's very important we should use at least 22 French, because the 22 French is of a nice lumen, so that it goes and takes the iTind into the lumen, and when you remove the catheter, the iTind will get removed comfortably. If you use anything less than 22 French like 18 French or 20 French, sometimes the iTind may not get into the catheter correctly and it will be quite uncomfortable for the patient. The 22 French open-ended catheter, you can use any catheter which is available. Silicone is better because it is quite sturdy and it will help you to remove it with much more confidence.
Anand, nice to see you again. There is some error in microphone here. We are unable to listen to you.
Okay.
So I think you are listening us. So taking an opportunity, and it's a nice talk. Especially your video presentation was very good, and it is easy to understand for us and our residents as well. One thing you have mentioned about the age, which was 50 to 90 years. You think about the size of the prostate. Is it matters in the treatment of this treatment? 60.
Yes.
Number two, because what is the depth of this cut? Because as far as my understanding, that the cut, when you are going deeper, and it is deeper as it touches to the capsule of the prostate, and then prostate sometimes bleed, because the main culprit of outlet obstruction is the median lobe, and if the median lobe bleed, it would increase the obstructive symptoms of the patient. What is your take in both of these points? Thank you.
Yeah, I will answer the questions. So first of all, presence of the median lobe. Maybe you can mute there. There is some echoing, isn't it? Yeah, that's good. So can you hear me now? Show me thumbs up. Can you hear me? Okay. Yeah, that's good. So first of all, median lobe is a contraindication for iTind. We can do median lobe for resume. We can do median lobe for Eurolift, Urolift has got a specific technique by which we can do the median lobe. It is known as mid-lift technique. So we can use the Urolift to pin the median lobe also. But iTind, as you can see, it cuts mainly the bladder neck and also the prostate, but it won't address the median lobe. So if there is a median lobe, there is an absolute contraindication. So we can't do iTind for patients with median lobe. Why we say the prostate size 60 cc is up to 60 cc. In the animal experiments, they have seen that the iTind, when it opens, it goes to the volume so that the prostate size is 60 cc. If the prostate is more than 60 cc, then the depth of the cut what the iTind is making is not good enough, and there will be lot of tissues after the cutting, so the prostate can grow back quickly. That's where the late failure happens. If the prostate size is 70 cc or 80 cc, patient may have good improvement maybe for 1 year or 2 year, but in long run, third year, fifth year, the patient may fail. But if it is less than 60 cc, the outcome will be little more longer and better. And I will answer the few questions from the previous question before we reconnected the Zoom. So this 22 French catheter is any catheter, silicone catheter. You can buy it separately, but I'm sure by the time it comes to Pakistan, this is from Olympus company, which is now well established company. I saw Olympus people in the POWS conference also. So I'm sure they will be able to supply a catheter, because catheter is very cheap and compared to the price for the implant itself. And then you can argue in both angles whether we really need this. I always think plenty of times, like, why we need this iTind, why we need the Urolift, why we need the Resume. If the patient fails medical treatment, we'll go for a proper TURP, because we are all trained like that. A proper TURP, complete resection of the median lobe, capsule to capsule, 360-degree resection, bladder neck to veru, create a beautiful cavity, put the catheter, nice hemostasis, one day, maybe next day remove the catheter, irrigation for 2-3 hours, maybe traction if needed. That's it. Patient voids urine like 16-year-old or 20-year-old age, and voids like a child, I will say. So why we are bringing all these small things which will not give that excellent cavitatory outcome like TURP or enucleation, but at the same time the outcome is okay? It is because it serves a particular group of a patient. It's not for everyone. It's not for somebody like I'm 80-year-old, my prostate is 60 cc, I finished my sexual work, I am not interested in sex anymore. For those patients, there is no need to discuss all these things. We can do a proper TURP and give him the best quality of life. But I'm sure you will come across young patients, 50-year-old, 55-year-old, maybe much more young wife like 30-year-old or 35-year-old, or even the wife may be also 50-year-old. It doesn't matter. If the man wants to say, doctor, I think the tamsulosin or finasteride is not working. Tamsulosin gives me absence of ejaculation. Finasteride gives problems with libido and also the erections. Now, I don't like the surgery. I don't want to lose my sex potency. I don't want to do disservice to my wife. So if some situation like this happens, we don't have any answer, say 15 years back, 20 years back. We need to say, sorry, there is no other answer. You need to come for TURP, or you need to put up with your urine works. But now it's a kind of a middleman. Patient is not happy to go for TURP, and patient's medications were not working. These things, Urolift, iTind, Resume, definitely have a place. I am very cautious in the Western medicine finding something and trying to put them into the developing countries with lot of cost implications, etc. But this one definitely has its own role. So if we practice it very selectively for correct group of patients with appropriate counseling, it gives good relief. And when you see the patients post-operatively with like good relief, passing urine satisfactorily, and they say, yes doctor, I'm able to pass urine well, and things are going well, sex or ejection or ejaculation is not affected, that gives him a quality of life for next 3 years or 7 years. And who wants to lose the sexual potency for maybe 5 to 7 years, isn't it? And in Eurolift also, again, it's the same story. There are some people after 5 years, when Eurolift is not working well, when the cystoscope shows that regrown, people have done second Eurolift after 5 years. That gives another 5 years of good quality of life. It all depends upon, number one, what the particular patient wants. Number two, is the patient is eligible. Say for example, if the prostate is say 100 cc, then we can't discuss anything. Either Eurolift, resume or iTind, none of them we can discuss. The patient has to go for medicines and suffer if it's not working, or go for a proper TURP or enucleation procedure. So the need to do this procedure, because it is modern, because it is ambulatory, because it is a short hospital stay, because it's no bleeding, etc. Those are all very small reasons. The big reason is real patient factors. We have seen patients traveling from Middle East all the way to UK requesting for these surgeries and having especially Eurolift done, because in Middle East it's quite in the early stages. And I traveled extensively in Saudi, Pakistan. Now I attended, and also I've done lots of workshops in India, and there are good cream of patients who are very thankful. The problem comes only if the doctors got this training and said, okay, I've got the training now I need to do more patients, and then only unnecessarily we will select patients who are of larger prostate, who really don't require the procedure, who may be better served by TURP. As long as the technique is good, patient selection is good, the outcome is also will be good. It's muted, Jawad.
Can you hear me?
Yeah, I can hear now. Yeah.
Basically, pleasure to have you on Zoom. Rather, me and my team is feeling you are physically with us. So once again, I would like to thanks on behalf of the Department of Urology Lungs, and thank you very much for sparing time with us, for me, for my faculty, for postgraduates, and see you soon again. And hopefully, I'm going to have a calendar of this Zoom lectures after coming up 3 years, as I have talked to some other friends around the globe. So that will be more better for us for saving time and everything. Thank you very much.
Sure. Jawad, there is one question in the chat box. I will just answer it before we complete. There is a question on how to estimate the prostate size. The best way to estimate the prostate size is ultrasound. There is no doubt in it. So it may be a transabdominal ultrasound or transrectal ultrasound, so that we can get the exact size, and also we can see the intravesical protrusion, the median lobe measurement. And also these procedures, it's nice if you can do a cystoscope before the procedure, so that you will know how big is the prostate, is it too much obstructing, or how high is the bladder neck, etc. So now we have 2-3 procedures to choose from. So if the patient has got small median lobe, which is doable, Eurolift is a good one. Quite large median lobe, almost a centimeter or more, resume is a good one. No median lobe but only bladder neck, iTind is a good one. And optilume is another one which is coming in a big way. Maybe next time when I have the option, I will try to do a presentation on the optilume. So transrectal ultrasound is the best way. If the patient is having MRI for any reasons, that's another one thing. And but once you start doing this procedure, once you do multiple digital rectal examination, with experience you will become more comfortable. The other question is iTind available in different sizes? No, it comes only in one size, but I'm sure the day will come, they may be able to produce sizes of slightly bigger for the larger prostates. So it's possible, but as of now, iTind comes in only one size. And thank you very much for all the time. And it's nice to discuss. It's nice to know what's happening across the continent. Otherwise, you will be just googling or learning all these things in various journal publications or something, but it's nice to talk to the person so that you can get some real world, real practice experiments also. And I love doing these sessions, and thank you, Professor Jawad, for this wonderful opportunity. I'm happy to do any teaching in the future also.